Now we're better. Good afternoon, everyone. All right, I'm going to ask, as they're cleaning, this is the afternoon session. It's on the status of sickle cell disease. I'm going to ask for some audience participation in a different way. First thing, I need everybody to stand up, please. Everybody stand up. Now, from where I'm sitting, there are 3 rows of tables. I need everybody to be in the first 3 rows. So y'all in the last 2 rows, get your stuff, slide on forward, because we're going to have a discussion, which means interaction, which means we have to be closer. So last 2 rows, and I will come down and walk among you because I'm not afraid to do that. So the last 2 rows, stand up, come in the first 3 rows so we can get closer together. All right. You were here before. Yeah, you know. Right. I know we got a lot of energy. We're not quite there yet. I see some people working on it. Good. Yes. In the back, lead y'all to come forward. Come on forward. Yep, y'all forward. Bring it forward. Okay. I got 3 minutes left for the intro. We'll spend all of them bringing everybody forward. We all go. Y'all, need y'all to come forward. All right. I'll walk around while y'all present. We'll get everyone up here. Because we're in that period of time after lunch where we could fall asleep, but we don't want that to happen. We got a great. Okay, we'll get settled down. Good. Okay. So I still need those folks in the last 2 rows to come forward. I'm going to do some introductions. You guys make, like y'all in the back over there, need you to come forward. Yep, come on up. Come on closer. Yeah, come on up. Y'all forward. Yep, come on up. Yep, come on up. We got lots of space up here. And why that's important, because the 3 speakers that we have that I'm going to share with you about, they spent a great amount of time preparing their presentation. We've got about an hour because they've asked us to keep it close. And we want to have an engaged discussion, right? So they've asked me to be the moderator. My name is Bert Bruce. I work at Pfizer. I'm the Vice President of Commercial Development for Rare Disease. None of that matters. What they've asked me to do today is to moderate a discussion around the status of sickle cell disease and other related blood disorders in America. So I started checking on a few things, like I used to do when my mom told me if I didn't know what a word meant to look it up. How many people had that happen? Yeah, and what'd you have to do? You had to go pull out the dictionary, and then you asked her what the word, and she said, try yourself first, and because she wouldn't tell me how to spell it. And now we just pull out the phone and we could look it up. And my kids don't understand what a dictionary is, right? But moderator led me to leads a discussion. So the key word was there was discussion. Discussion then led to conversation. Then a conversation led to this really cool definition of an oral exchange of sentiments, observations, opinions, or ideas, which is what we're going to have. But remember, we said there's an oral exchange, which means some people need to share information, others need to receive that information, and then they need to send some back, right? So see how we get closer and everybody. So we have 3 speakers. They're going to be brief so that we can have an exchange of information, and we're going to do this all in the next 45 minutes. I'm going to introduce the speakers in reverse order so that when I get done speaking, we'll hear from the first speaker. The third speaker that you will hear is Dr. Craig Cole. He's a board-certified hematologist at the University of Michigan. Yes. Comprehensive Cancer Center in Ann Arbor. Dr. Cole's clinical research interests include multiple myeloma, non-Hodgkin's lymphoma, and therapeutic apheresis. He's been the on-site primary investigator for over 21 clinical trials, has published and presented his research at the American Society of Hematology and other National Medical Association meetings. His presentation today is going to focus on the impact of myeloma among African Americans. So I expect that you will be able to talk to him about clinical trials, about the presentation of information, and things in that nature related to myeloma or other concerns. The second speaker you will hear is Sonja Banks, who I've had the pleasure to get to know a little bit over the course of the past year. She is the President and Chief Operating Officer for the Sickle Cell Disease Association of America and is primarily responsible for the administrative activities of the organization, which serves over 55 sickle cell community-based organizations throughout the United States. An accomplished management professional with over 17 years of executive level experience and an established background in nonprofit leadership and operations, she is going to talk about the role of community and patient advocacy in the success of new therapies and programs. But beginning us off, like I just love, this is going to be Althea Grant, PhD, Captain Althea Grant. I like that because in this introduction I get to say it like 4 times. Captain Althea Grant is the Chief of Epidemiology and Surveillance Branch in the Division of Blood Disorders within National Center on Birth Defects and Developmental Disabilities, Centers for Disease Control and Prevention. Captain Grant is a recognized national leader championing public health programs for hemoglobinopathies such as sickle cell disease and thalassemia. She served as the CDC's project director for the RUSH program, the first population-based public health surveillance system for sickle cell disease and thalassemia conducted in collaboration with the NIH and the NLBI. In 2009, she received a Commendation Medal from the U.S. Public Health Service in recognition for developing programs to improve the health of individuals affected by sickle cell disease. I appreciate you guys' flexibility in letting somebody that you don't know tell you what to do so we can get closer. Please turn your attention now to Dr. Grant as she shares with us an overview of the public health burden and opportunities to improve health outcomes.
To thank the organizers for inviting me to present a general overview of the burden of sickle cell disease and some opportunities to improve health outcomes. I'm going to begin the presentation really by giving you a real basic overview of sickle cell disease. I know we have a mixed audience, and everyone may not be as familiar as some of the people on the stage with sickle cell disease. So if you know a lot of this, just bear with me. I'm going to talk a little bit about the history of sickle cell disease and public health in the United States, and then I'm going to end by talking about some of the areas where we have some missed opportunities, some gaps that we need to close, and where we all in this audience can make a difference. So sickle cell disease is a group of inherited red blood cell disorders that is caused by a mutation in the hemoglobin gene. This mutation causes cells to make an abnormal hemoglobin. So in states of low oxygen, that abnormal hemoglobin deforms red blood cells, causes those cells to stick together, causing blockages of small vessels. These clumps of red cells block blood flow in blood vessels that lead to limbs and organs, and these blocked blood vessels can cause pain, serious infection, and organ damage. In addition, these sickle red blood cells are very fragile. They hemolyze, which means they break apart very easily and are rapidly removed from the blood. So whereas normal red blood cells might live 90 to 120 days, these sickle red blood cells only live 10 to 20 days, and this contributes to the anemia that we observe when we talk about sickle cell anemia. So sickle cell disease can cause a lot of major complications. Besides the anemia, sickle cell disease can cause splenic sequestration. Infants often died of infections early in childhood with sickle cell disease. The hallmark of sickle cell disease is painful crisis, and we often hear about painful crises. But sickle cell disease also is a leading cause of stroke, particularly in children. It causes acute chest syndrome and all types of organ damage, pulmonary hypertension, leg ulcers, and the list goes on and on. So sickle cell disease is caused, as I mentioned before, by a mutation in the hemoglobin molecule. If you have 2 copies of that mutation, which we refer to as the S, you are homozygous, and we refer to you as having sickle cell anemia. If you have only 1 copy of that mutation, we usually say you do not have the disease, but we refer to these individuals as having sickle cell trait. And people with sickle cell trait can live normal lives, but they can pass on that S hemoglobin to their children. There are other forms of sickle cell disease besides sickle cell anemia, which is the SS form. People can inherit another abnormal hemoglobin called hemoglobin C and have a form of sickle cell disease called hemoglobin SC disease. People can also inherit an abnormal hemoglobin called beta thalassemia, either beta plus or beta zero, and have a form of the disease that we refer to as sickle beta thal. So who does sickle cell disease affect? The distribution of sickle cell disease and sickle cell trait reflects the fact that sickle cell trait confers a survival advantage against malaria, and that this selective pressure due to malaria has resulted in high frequencies of the sickle cell mutation in areas of high malarial transmission. So on the left map, you see areas of the world with high malaria prevalence in brown. And you can see on the right map that there's a high prevalence of the sickle cell gene in areas with a similar distribution to that of malaria. For this reason, sickle cell disease is particularly common among people whose ancestors come from sub-Saharan Africa, India, Saudi Arabia, and Mediterranean countries. And because of the migration of individuals whose ancestors come from these regions, sickle cell disease affects a significant number of people in all parts of the world, including the Americas. So in the United States, we estimate, and I use the word estimate in quotes, that approximately 80 to 100,000 Americans have sickle cell disease. We do not know the exact prevalence, and I'll talk a little bit about what we're doing at CDC to try to address this issue later in the talk. But we also know that approximately 1,800 to 2,000 infants each year are born in the United States with sickle cell disease, and that the incidence is about 1 in every 365 African Americans, about 1 in 1,400 to 1 in 36,000 Hispanic Americans, depending on their ancestry, and 1 in 80,000 whites. We also estimate that over 3 million Americans have sickle cell trait. That is not an exact number, although at CDC we hope to have a more precise number by the fall of how many Americans have trait. And we see sickle cell trait occurring in approximately every 1 in 12 African Americans. So it has been approximately 104 years since the publication of the first case report of sickle cell disease in the literature, which occurred in 1910. It was published in the Archives of Internal Medicine by Dr. James Herrick and was entitled Peculiar Elongated and Sickle-Shaped Red Blood Corpuscles in a Case of Severe Anemia. Interestingly enough, Dr. Herrick described the experience of a young dental student from Grenada attending the Chicago College of Dentistry. Soon after arriving to dental school, the student sought medical attention, and abnormal-shaped red blood cells in the student were first noted. I think it's interesting to note in sickle cell's history, although African Americans clearly have been in the United States for hundreds of years, that the first report of sickle cell disease was actually identified in an immigrant to the United States. In 1949, 2 papers were published independently by James Neal and Colonel E. Beat, demonstrating that sickle cell disease was indeed an inherited disorder, and that people with sickle cell trait were heterozygous for the disorder, and that people with SS were homozygous for the disorder. And then in 1951, Pauling and Itano discovered that the hemoglobin of people with sickle cell disease had a different chemical structure, and they coined the term molecular disease. And so sickle cell disease has the honor of being identified as the first molecular disease. In 1956, Ingram and Hunt identified the actual amino acid substitution that led to sickle cell disease. And despite this long scientific history, one would argue that public health strides for sickle cell disease really did not begin until around the 1970s, and really began in 1972 with the National Sickle Cell Control Act. In 1972, President Nixon signed the National Sickle Cell Anemia Control Act, And the goals of the act were the following: to reduce the morbidity and mortality of sickle cell disease, to increase awareness by educating the public, and to develop new modes of therapy. The act created funds for mandatory carrier screening and counseling, information and educational activities for healthcare professionals and the general public, and research training in diagnosis, treatment, and management of the disease. Subsequent to the act, there were many strides in sickle cell disease. Prior to the 1970s and this act, the life expectancy of people with sickle cell disease was low in the United States, with the survival being noted as only 14.3 years in a study published in 1970. However, since the 1970s, in part due to the investments made after the Sickle Cell Anemia Control Act, critical measures were implemented that resulted in dramatic improvements in life expectancies and health outcomes. One of the public health programs that emerged was universal newborn screening programs for sickle cell disease. The top graph shows the number of states implementing newborn screening for sickle cell by year. Newborn screening began in 1975 in New York, but really took off after the NIH recommended universal newborn screening for sickle cell disease in 1987. And by 2006, all states in the United States were screening universally for sickle cell disease. Newborn screening facilitated widespread receipt of effective interventions such as penicillin prophylaxis up to age 5, pneumococcal vaccination, comprehensive health care, particularly at the pediatric stage. All of these things led to improvements in length and quality of life of children and young adults with sickle cell disease in the US. So as a result, although the life expectancy was only noted as 14 years prior to the 1970s, the median survival noted by investigators from the Cooperative Study of Sickle Cell Disease that followed patients from 1978 to 1988 noted that the median life expectancy was 42 years for males and 48 years for females. And now today we see over 90% of children with sickle cell disease live into adulthood. So despite these past improvements, today there are still many challenges that affect people with sickle cell disease. So this is a conference on health disparities, and health disparities are differences in incidence, prevalence, mortality, and burden of disease and other health conditions that exist among specific population groups in the US. And people with sickle cell disease experience these differences. Many people affected by sickle cell disease experience higher morbidity, higher mortality compared to the general population, and there's a tendency to attribute that to a biological determinant of having a severe disease. But data suggests that even in the context of sickle cell disease, a severe disorder, more can be done to improve the health outcomes and quality of life of those affected. For instance, about 20 to 30% of children with hemoglobin SS or sickle cell anemia experience stroke. This stroke can lead to cognitive impairment that can lead to lifelong disability. Sickle cell disease accounts for 23% of pediatric stroke cases among African Americans. A paper that I'm preparing with one of my fellows demonstrates that this is the leading cause of pediatric stroke among African Americans. But there are ways to address this. Transcranial Doppler screening is an ultrasonography tool that can be used to identify children with sickle cell who are at high risk for stroke. And those determined to be at high risk can begin chronic red cell transfusion, which has been shown to reduce the risk of stroke by 90%. But unfortunately, selected studies show that only about a third of children with sickle cell disease are receiving TCD screening at the appropriate intervals. With respect to disease-modifying therapies, there is only one FDA-approved drug for sickle cell disease, and that drug is hydroxyurea. It is clear from clinical trials and other studies that hydroxyurea decreases morbidity and mortality for people with sickle cell disease. It is also clear from studies that have been co-authored by scientists at the CDC that hydroxyurea not only provides better outcomes for people, but it is also cost-effective and cost savings. In analysis of the clinical trial looking at hydroxyurea efficacy in children, we found that children who received hydroxyurea treatment had nearly a third fewer hospital stays, and also the total cost of care for children in and outside the hospital was reduced by 21%. And because a large proportion of people with sickle cell disease are covered by public insurance programs like Medicaid and Medicare, use of hydroxyurea would reduce costs to these programs. However, studies suggest that hydroxyurea is severely underutilized. Small studies of claims data suggest that only 14 to 17% of patients with sickle cell disease are prescribed hydroxyurea, and that among those prescribed hydroxyurea, only a third are adherent to therapy. Despite the fact that we have universal newborn screening, there is still a great unmet need for education and counseling, particularly of carriers with sickle cell trait. As I mentioned earlier, we anticipate that there are over 3 million Americans who have sickle cell trait, but many of these Americans are unaware of their status or its implications. I just want to do a quick test to the audience. How many people in the audience know whether or not they have sickle cell trait? And how many of people in the audience know how that affects their hemoglobin A1C level or testing? So very, very few. And so the point is that even though people may be aware that they have trait, they may not know what it means, they may not know how to engage their provider or what guidance they should be given. The other thing is that many of the people who have sickle cell trait were born prior to universal newborn screening, or in places where there is no screening and counseling programs, for instance, in foreign countries. As part of our surveillance program, one of the things we looked at is country of origin of the moms who had children with sickle cell disease. And we did this analysis in New York, for instance. And we found actually that the majority of infants born with sickle cell disease in the state of New York were born to mothers who were foreign born. So many of those mothers may have been unaware of their status, their sickle cell status, prior to having a child. And studies show, for instance, a study by Mosley and colleagues show that parents of children with sickle cell trait are less likely to receive the appropriate genetic counseling than parents of children with other genetic disorders like cystic fibrosis. So people with sickle cell disease face a lot of challenges, and a lot of these challenges are with respect to healthcare access and healthcare quality. The majority of people affected by sickle cell disease in the United States now are adults, but many adults with sickle cell disease do not have a medical home or a primary care provider. There are very few specialists for the adult population. These adults often experience frequent emergency department visits, hospitalizations, and rehospitalizations. Data shows that there are over 200,000 emergency department visits associated with sickle cell disease each year. Adults account for 66% of those hospitalizations. The adult healthcare cost is triple that of children. Adults account for the vast majority of the population. And among those hospital stays, for sickle cell disease, almost 80% are paid by public insurance programs like Medicare and Medicaid. In this slide really underscores the effect of lack of access and quality of care, particularly for adults. It is a slide from some data that we collected as part of a surveillance project over the periods of 2004 and 2008 in Georgia and California. There are actually 7 states in this project, and I only put 2 on the slide, and it really wouldn't matter which state I would put up. The graph would look very, very similar. And one of the things that we note and confirm with this real-life data on thousands of patients in these particular states is that once people reach adulthood, we see emergency department visits jump dramatically. We generally see tripling of emergency department visits because often adults don't have access to good primary care and good specialists. Adults also experience longer wait times in emergency rooms when they are able to access care. And then there's definitely a lot of stigma. Disparities in pain management and stigmatization as being drug seeking is a common complaint among patients with sickle cell disease. So underlying the healthcare disparities in sickle cell disease are inequities in investments to address sickle cell disease. So this slide is from a 2006 paper by Smith and colleagues comparing the spending on sickle cell disease to another genetic disorder, cystic fibrosis. And I'm not going to go through the slide for the sake of time, but the bottom line is that the per person expenditure on cystic fibrosis was approximately about 8 times more than that of sickle cell disease. And this data is about a decade old, but recent data that I've seen at a meeting, someone did a reanalysis of current data and the disparity has not closed at all. And in fact, I think the disparity may have been a little wider in his reanalysis of data. So although this paper was published a long time ago, it really accentuates the fact that we have a long way to go in reducing the resource disparities for sickle cell disease. So I'm going to end with the last few slides talking about what we see as some of the public health needs for this population. One of the things that's clear is that we need better high quality and coordinated care, especially for adults. We tend to do really well with children, and in fact, an analysis that I'm engaged in now shows that we don't see higher rates of mortality for children in some states compared to children without disease, showing that we're making huge strides for children, but we see dramatically increased rates of mortality for adults. We need updated and uniform clinical care guidelines, and NIH is currently working on these right now. We need accurate estimates of health status and health indicators, and CDC is really working hard to get these things now. We need increased utilization of effective interventions like hydroxyurea, TCD screening, and the list goes on. And we also need better education and community awareness. And one of the things I just want to note about sickle cell disease, what sickle cell disease has taught me during my career at CDC, I wasn't always working in sickle cell disease, but sickle cell specifically has taught me the value of partnerships. And so although I mentioned briefly some of the work that federal agencies are doing, there are 1 million partners who play a critical role in sickle cell disease, including state health departments, specialized clinical centers, national and local community-based organizations like SCDAA, which we'll hear from in a minute, organizations that oversee newborn screening like the Association of Public Health Laboratories, professional organizations like the American Society of Hematology, private sector, and industry, and hopefully many of you in the audience. So I want to end by saying, by showing this slide, which is the life expectancy of individuals with sickle cell disease compared to the life expectancies of other Americans. And one of the things that's really noteworthy in this slide is that you can see that there was an exponential growth in the life expectancy of people with sickle cell disease after investments were made post-1970 into public health. But the other thing that is noteworthy is that there's still a dramatic gap, at least 2 to 3 decades short of life expectancy for individuals with sickle cell disease compared to other Americans. But what if we were as effective in assuring access to interventions like TCD screening and hydroxyurea and other new therapies that will come out as we have been with newborn screening, penicillin, prophylaxis, and vaccination? What if the care was of as high quality for sickle cell disease as it is for other genetic disorders like cystic fibrosis or hemophilia or others? I'm wondering, could we close this gap? Thank you.
Thank you, Dr. Grant. Can everyone hear me? Good afternoon. So I'm going to try to make this brief. Dr. Grant has covered a lot of the key points that I was going to make, and that's a great thing, so that we can get you out of here in a timely fashion. So I promise to be brief. I am Sonja Banks. Again, I'm the president and COO for the Sickle Cell Disease Association of America. And I want to talk today a little bit about the role of community and patient advocacy, especially when it comes to success in having new therapies and new programs for sickle cell disease. I am not a doctor by trade. I actually have a master's in public administration, and my background is in nonprofit management. So my focus standing in front of you today is really advocacy and being an advocate and what the importance is of being an advocate, whether you are a community advocate or whether you are a patient advocate. It is so essential, as you heard Dr. Grant talk about the challenges in sickle cell disease, that we come together as a unit, one unit, unifying to conquer this disease. So with that said, I want to talk a little bit first about SCDAA and who we are. The Sickle Cell Disease Association of America serves as the nation's, we are the only voluntary organization in the U.S., but we also are the nation's oldest and largest advocacy organization, working full-time on the national level to resolve issues surrounding sickle cell disease. Our mission, of course, is to advocate for and enhance our membership's ability to improve the quality of health, life, and services for individuals, families, and communities affected by sickle cell disease and related conditions, while promoting the search for a cure for all people in the world with sickle cell. These are briefly our services. I will not go over each individual service, but we are focusing on national awareness, research support, professional health education, public health education, capacity building for our member organizations because we are chapter-based, and of course, advocacy. Very important, SCDA started because a group of community-based organizations decided that they wanted to take initiative in bringing awareness to sickle cell disease. These were CBOs or community-based organizations that were already established. They already had their 501c3s and were independent nonprofits. But what they wanted to do was look at the problem overall. These conversations started in the late 60s, and in the late 70s or mid 70s, SCDAA was founded. So I wanted to really focus on our members for a moment because our community-based organizations basically are designed to serve individuals and families in their respective communities by offering programs and outreach services. These are the services that you hear a lot of Dr. Grant talked about. They are testing, screening, support services. Our member organizations are strategic in making sure that patients and families have transportation services, that they have prescription assistance, burial assistance, any assistance that will help eliminate barriers. That's what our chapters do. They assist clients with finding quality health care, maintain databases of individuals and families with sickle cell disease. They perform community outreach, and they educate local communities. Some of our accomplishments, these are not close to the accomplishments that SCDA has been able to have over its 42 years. We are 42 years of age this year in September. But SCDAA was instrumental in establishing sickle cell disease as a national public health priority through HHS. In 2011, Secretary Kathleen Sebelius announced that sickle cell disease should be considered or looked at as a national public health priority. SCDAA also has accomplishments in extensive legislation. The Sickle Cell Treatment Act of 2003, which we'll touch on, the reauthorization, was spearheaded through a grassroots effort by SCDAA. In addition, SCDAA has been responsible for helping to secure or procure about $40 million over the last, 20 years for sickle cell disease. And also SCDAA, through two of our champions and our board members, Dr. Kwaku Ohene Frimpong and Dr. Lynette Benjamin, actually secured program funding for newborn screening follow-up. So when you hear Dr. Grant talk about newborn screening in the States, there was a follow-up program, or is a newborn screening follow-up program, where we actually go out and educate through our communities, educate parents whose babies have been diagnosed with sickle cell disease. We have over 48 member organizations. I heard in my bio that we had over 55, and we have reduced that number. We actually have about 49 chapters located in about 30 states in the United States. SCDAA spearheaded last year, which is one of our proudest accomplishments, the establishment of a congressional caucus on sickle cell disease. That caucus was actually established this year in January, and it is spearheaded by Congressman Charles Rangel, and co-chaired by Congressman Danny Davis out of Chicago, Illinois, and Congressman Tim Scott out of South Carolina. In addition, SCDA has awarded over $1 million in scholarships and fellowships. Most of our fellowships and scholarship programs are for individuals with sickle cell disease, and our fellows programs are individuals who have an interest or take an interest in what's going on in sickle cell disease research. And lastly, we have established ourselves as really distributing educational materials nationally. So community and patient advocacy, influencing the success of new therapies and programs. I wanted to, in order to really understand sickle cell advocacy, just touch on advocacy yesterday and advocacy today. So sickle cell disease advocacy actually started in the 60s when there was this people were taking notice of sickle cell disease and why it wasn't being given any attention to. And so what happened was a group of scientists, along with a group of community leaders, decided that they really wanted to bring forth sickle cell disease and put it out there for people to understand what it was. In the 1960s, you saw this huge surge of awareness taking place with sickle cell disease. And what happened was, after looking at what was going on, they noticed that there were a lot of babies diagnosed with sickle cell disease that were dying. And so the goal at that time was, how do we stop these babies from dying? How do we prevent that? What do we do to allow them to live longer and more prosperous lives? And because of that, the establishment of sickle cell clinics and screening, education, counseling centers, all of these individuals began to come together to look at this disease and take a look at it. As a result, morbidity and mortality significantly decreased in children due to newborn screening. Dr. Grant already talked about penicillin prophylaxis, stroke prevention, and this was all due to a surge in clinical research and effective management. Sickle cell disease advocacy today. So the fight must continue. You heard Dr. Grant talk a little bit about how now our babies are living, how that has actually improved over the years. But there's still an estimated life expectancy for someone with sickle cell disease of the mid-40s. And I don't know about you, but I'm hearing that the new 30 is 20, which means that the new 40 is the 30. And that is prime. It scares me to stand up here in my 40s and for someone to tell me that I may not live. Now, I don't have sickle cell disease, but imagine someone who has sickle cell disease and hearing these kinds of numbers, that your estimated life expectancy is in your mid-40s, which is prime. That's the time when our lives are really beginning. So now our advocacy efforts continue to seek solutions for transition issues that we're having, increasing mortality of young and older adults. There's an overwhelming need for improved pediatric to adult transition services. There's also limited knowledge of primary care providers about sickle cell disease treatment. So key roles, what can we do as advocates. We can influence, elevate, educate, and participate. We can influence key legislation and change policy. Sickle cell disease receives significantly disproportionate amounts of funding for its programs compared to comparable diseases. I'm glad that Dr. Grant put the slide on there to show you cystic fibrosis, but about 3 years ago, I came into the office and said, let's look at what other diseases are receiving overall federally. And what I came to find out astonishingly is that sickle cell disease receives about 40 to 45% less in funding than these other diseases. Now, blood disorders as a whole already receive a disproportionate amount. And so now you look at sickle cell disease as one of those blood diseases being 42 to 45% less. Just one example is sickle cell disease has no line item in the CDC's budget. There is no line item. That's because we really need to advocate for that to be put into the CDC's budget. The Sickle Cell Treatment Act has expired. So you heard me talk about we were good spearheading the Sickle Cell Disease Treatment Act in 2003. It expired about 3 years ago. We've been gracious enough to have been held in the president's budget over the years, but that has come to an end. And so now it is more important than ever that we get the Sickle Cell Disease Treatment Act reauthorized. That bill is expected to go on the floor in the next 2 weeks, hopefully. And my hope standing here today is that everyone in this room find a way to support that. The need is for a comprehensive care model to ensure access to high quality care for sickle cell disease consumers at large. So this is what we can do. Join in a collaborative legislative agenda. Now, everyone in here, especially if you are with an organization, association, or company, you have your own legislative agenda. When you're on the Hill, you're advocating for what you need. What I'm asking and proposing is that you join in with us with this agenda. It's not to take away from your agenda, but it's to add to it, to say that as a part of my legislative agenda, I also want to advocate for sickle cell disease and advocate for the Sickle Cell Disease Treatment Act. Advocate for increased sickle cell funding among federal agencies, particularly HHS. Make it a component of your legislative agenda. Get your legislative champions, whoever they may be, to support sickle cell disease and to join the Congressional Sickle Cell Disease Caucus. Forge good relationships and collaborations with HHS agencies and continuously reiterate the importance of a comprehensive model of care. Again, you already have, a lot of you in this room, relationships in those areas with your congressional leaders, with individuals with HHS. What I'm asking is that we join together to just make sickle cell disease a part of what you talk about. Next, we can elevate awareness. We all know that sickle cell disease does not receive mainstream focus. I'll stand up here and tell you, as a national president, our budgets are not, the SCDA's budget is not nearly close to what you see other national organizations' budgets be. And with that, we're limited in how we spread the word. But the great thing about it is that we now have social media, which is essentially free, that we can start really, really raising awareness, but it's going to take your help also. Correlation between increased funding and increased awareness is large. We all know that if people don't know who you are and what you are, they're not giving. So we have to make the correlation. SCD, meaning sickle cell disease, needs to be a national priority. A national priority. It was interesting because I actually got here a little bit before lunch, and I saw all the wonderful presentations, and I saw all the diseases in the presentations, but I didn't see sickle cell disease. And this is something that I want to advocate for standing here, is that you make that a part of your agenda, that we do become a part of a national priority. What can we do today? First, we just talked about it, make SCD, sickle cell disease, a part of your national agenda and your organizations, not just your legislative agenda, but your national agenda to raise awareness and educate. Utilize social media weekly to raise awareness. Partner with key organizations to create national sickle cell disease public service campaigns. Educate and share knowledge with those that can influence. We already know the challenge is the knowledge base of sickle cell disease among healthcare providers. Federally funded newborn screening follow-up programs are available, but only in 7 states. And there's a misperception or conception about why or sickle cell disease as it exists. What we can do, influence your networks and partners to include sickle cell disease in all of your information, on your websites. When you disseminate information, your strategy should be to include sickle cell disease. Advocate for and utilize CBOs. As I mentioned, we have 49 in over 30 states. Figure out who they are. You can go on our website and work with them. And then bring attention to the disparities that exist within sickle cell disease. Last but not least, and I won't spend a lot of time on this because there's the great presentation that was done on I'm in, and I stand here before you saying that SCDAA is in. We are in to this campaign. The challenge, clinical research trial participation is a challenge as a whole. We already know that. There's a general distrust in the medical health care system that still exists among African Americans and minorities. And historical events, which was mentioned during lunch, the Tuskegee experiment, basically has given us reason to doubt or mistrust. So we have to change that. I wanted to put these stats on here so that you can see that there's a significant percentage of Americans say it's very important to volunteer for clinical trials. So you can see that African Americans and Hispanics and Asians, we all feel that clinical trials are extremely important. However, the next slide shows you, or the next point shows you that only 5% African Americans, 1% Hispanic, and less than 3% Asian actually participate in trials. Only about a quarter of African Americans, Hispanics, and Asians say they have heard about a clinical trial from their doctors or others. And that's because we really need to spread the word. We need to take time to find out about clinical trials, what they are, how important, and we need to relay that information back to individuals with sickle cell disease or anyone that may be, suffering from some kind of health illness. What you can do, join in a national effort. So join the I'm In campaign. I love it. Help reestablish trust by educating those entities that influence patients and families. So how many times do we hear people say, I don't know about clinical trials, I'm afraid of them, I don't know anything about them. We need to go to the people that they trust. If you're a patient or a family member, who do you trust? Go to them and begin to influence them and educate them. That includes parents and caregivers, churches. A lot of African Americans, particularly, and Hispanics in the Catholic Church, they listen to their leaders, their Christian leaders. Their providers, if you are a healthcare provider, making this important, and their peers. And then disseminate information about open clinical trials as a part of your education plan. Those are just some things you can do. Last but not least, other ways to ensure success. I've heard this earlier, and so I'm glad someone else mentioned it other than me, but incorporate patient and family involvement at all levels. It's not good enough to create a program and then take it to a patient and family and expect for them to just jump on board. Try to involve them at every aspect of your decision making. Keep sickle cell disease community informed about what you're doing. Ensure transparency, and of course, utilize and embrace the value of community-based organizations. And together, these are the things that we can accomplish. We will ensure access to care, quality treatment, new therapies, increase clinical trial participation, increase awareness, and more importantly, find a universal cure. Thank you.
Those were two fantastic presentations. And at the risk of starting my talk with an inflammatory statement, I would say that as I'm an adult hematologist, I see patients with sickle cell, I see patients with multiple myeloma, and I'm going to talk about myeloma in just a second. But as much as I think that we need primary care providers, primary care nurses, physician's assistants, and people delivering care who are of ethnicity, I think it is critical that we have hematologists and we have people who are specifically trained in blood disorders to help with sickle cell and to help with things like multiple myeloma. And so I would encourage people to not only advocate and encourage people to go into primary care, but to go into hematology and be hematologists, because I absolutely love what I do. And I think it's important to see people of ethnicity doing research and participating in these diseases that affect our community. I'm going to talk about something a little bit different. Instead of sickle cell, I'm going to talk about a disease called multiple myeloma. And I am very aware that there aren't, how many people know about multiple myeloma? Who's heard of myeloma before? If you could raise, oh, thank goodness. So that makes my job much easier. But there are, and I'll talk about it in a second, there are a lot of people who don't know about multiple myeloma and its impact on the community. So I'm going to talk a little bit about the definitions of multiple myeloma, is a bit of anatomy and physiology, because that is always so good to have after lunch. And then I'm going to talk about what is myeloma, the incidence in African Americans, treatment, and how we have improved survival in this disease, the ethnic disparities in myeloma treatments, and testing for myeloma, and then how you can bring that back to your community, because what I would like to do is to recruit all of you as not only advocates for this disease, but also educators in your community for multiple myeloma. And my disclosures is that I have no, I got student debt like crazy, but I have no financial interest to disclose, and I work in the Government of Office Affairs at Onyx. So what is multiple myeloma? Or what are blood cancers? What are hematologic diseases? Is it bone cancer? People call it bone cancer. No. Bone cancer is a disease called sarcoma. It's very rare. It's a solid tumor. And it is not a hematologic or bone marrow cancer. Is hematologic diseases a cancer that has gone to the bones? No. That's called metastatic cancer or metastatic disease to the bone. So common cancers like lung cancer, breast cancer can metastasize to the bone, but those aren't bone marrow cancers. What hematologic or blood cancers are is that they are cancers of the blood cells, of the stem cells inside the bone marrow that produce the blood, and that is the correct answer. So here's a little bit of anatomy and physiology. Inside the bone, there's the solid bone, and inside the bone there's that mushy stuff called the bone marrow. And the bone marrow is actually a very, very heterogeneous population of cells. It is the blood factory, and inside the bone marrow there are the stem cells, and the stem cells make the red blood cells, white blood cells, and platelets that help us make blood clots and help us fight off infection. There are also, inside the bone marrow, there are lymphocytes, and the lymphocytes are part of the immune system, and they live in the bone marrow, they exit in and out of the lymph glands, and they also help fight infections. So when you get a toothache or a tooth infection and there's a swollen lymph gland, it's because the lymph nodes are in there fighting infection to remove you of infection. And then lastly, confined to the bone marrow compartment are the plasma cells. And the plasma cells, if the lymphocytes and white blood cells fight infection on the battlefield, the plasma cells are actually sending out antibodies to fight them from afar, like the infantry, or the artillery, I'm sorry. And they shoot antibodies at bacteria to fight infection. If the stem cells turn cancerous, that's called acute leukemia, and then the stem cells grow out of control and lower the blood counts. When people have lymphoma, it's a cancer of the lymphocytes, so the lymph cells, and then the lymph nodes can grow out of proportion because of infiltration of that disease. But multiple myeloma is a bit different. When people have myeloma, that's a cancer of the plasma cells, And it is, again, confined to the bone marrow compartment. And when those cells grow out of control, they produce massive amounts of protein that can be detected in the blood that actually drown out the normal immune system. So what is myeloma? Again, multiple myeloma, again, is a cancer of the plasma cells. That the plasma cells, again, when they become cancerous, they grow out of control. They produce excessive amounts of protein into the blood that can be detected using a blood test and a urine test called the serum protein electrophoresis that I'll talk about in a second. And again, the hallmark of the disease is that production of protein that can be detected in the blood and urine. The manifestations of multiple myeloma, 90% of patients have some type, when they present with myeloma, have some end organ disease related to it. They can have low blood counts and fatigue because the marrow compartment is being filled with myeloma cells, and the red blood cells that carry energy go down. It can cause kidney damage because that protein being produced in excess by the plasma cells gets stuck in the kidneys, causing kidney failure. And the plasma cells can leave the bone marrow compartment and go to the bone, causing bone pain and fractures. And there's an arm bone, and it's actually those plasma cells will leave the bone marrow and go to their next closest cousin, which are the hard bone cells, and then they can cause thinning of the bone, damage, and ultimately fractures and pain. The diagnosis of myeloma is made by doing blood tests. You can do blood tests to detect that extra protein or that monoclonal protein, that M protein in the blood and urine. You can do x-rays in order to find the places where the bone has softened and nearly fracturing. And ultimately, you do a bone marrow biopsy to see those excess numbers of plasma cells inside the bone marrow compartment. And that's what a bone marrow biopsy looks like with someone with myeloma. Again, with the bright blue cells being the malignant plasma cells. So last year, there were 22,000 cases of myeloma diagnosed in the United States. And one interesting point that when I was in training was a footnote in the textbooks about myeloma, but really is one of the critical pieces of information about this disease, that African Americans have twice the incidence of whites with multiple myeloma. The standard incidence is quoted at 5 per 100,000, and for African Americans it's 12 per 100,000. Here is the SEER database showing the incidence of myeloma from 2000 to 2009, and you can see that for multiple myeloma, among African Americans, the incidence is 11 per 100,000. For all races, 5 per 100,000. For Hispanics, 5.2 per 100,000. For Caucasians, 5.6. Native Americans, 4.9. And for people of Asian descent, 3.2. And the African Americans have the highest incidence of multiple myeloma of any ethnic group or race on the planet. The incidence, and I'll show you in a second how the incidence of myeloma increases with age, and the incidence in black males and females is 126% greater than similar older persons that are Caucasian in 2010. So from 2006 to 2010, using again the SEER data or the SEER database, myeloma was the 8th most common cancer among African American males, the 7th most common cancer among African American females, and the incidence rises with age. So again, using a SEER database, that the incidence peaks around 79 to 80 years of age, and the green bar is that of African Americans. The other bars are those of other races, and you can see that it is significantly higher in older African Americans than in other groups. So why do African Americans have such a high incidence of multiple myeloma? We don't know. When you look at the usual suspects for incidence disparities, the racial disparity and difference in multiple myeloma can't be explained by obesity, tobacco, dietary preferences, vitamin intake, family history, or socioeconomic status. We do not know why this disease is so common in African Americans, or on the flip side, why this disease is so uncommon in people of Asian descent. Molecular studies, cytogenetic studies have all looked at trying to figure out the difference. And when you look at cytogenetics and molecular differences of multiple myeloma between the races, there's really nothing that we can detect. However, there aren't enough African Americans with myeloma involved in clinical trials for us to detect some of those differences. And I'll talk about that in a second. One remarkable thing that has happened in multiple myeloma is that there's been significant advances in the treatment of myeloma. When I was much younger, much more hair, much more in debt actually. And when I was a resident and intern, the survival of multiple myeloma was 2 years, and only 30% of people responded to therapy, which was always chemotherapy, and it was basically a death sentence. Now that we have done now that so much research has gone into the biology of how multiple myeloma grows and how it's really dependent upon the microenvironment of the bone marrow. There's a reason why multiple myeloma is stuck in the bone marrow, because it's dependent upon the other cells, like the bone marrow stromal cells. It is very dependent upon new blood vessel growth inside the bone marrow, and it's dependent upon the osteoclast or the hard bone destroying cells in order to survive. Myeloma cells can't live without having its neighbors around it. And that has been a source of targeted therapies for myeloma. So now we have immunomodulatory therapy, we have proteasome inhibitors, and as an adult hematologist treating multiple myeloma, I rarely write for I don't give chemotherapy at all. At most, I give very weak chemotherapy pills. All the therapies I use to treat myeloma are all targeted therapies built and designed specifically for multiple myeloma, which has resulted in a revolution in how myeloma is treated. I don't understand why the story of myeloma and the change and the revolution in how well we treat the disease isn't on TV every week. There's all sorts of other stuff on TV that doesn't make any sense to me. And now with new biologic therapies targeted towards multiple myeloma, now we have response rates of 98%. So we went from 30% response rates to 98%. And the most recent clinical trials through 2013 have shown response rates of 100% for non-chemotherapy treatments for multiple myeloma. The survival has doubled to 6 years, and this is one of my favorite slides that I give, is that between the blue bar is 2004, the people living with multiple myeloma in the United States. The red bar is 2011, and the difference, all of a sudden, more people are living with multiple myeloma between 2004 and 2011. That isn't because a spaceship came down from the sky with a bunch of myeloma patients. It's because people stopped dying of multiple myeloma, where almost 20,000 people that would have died before 2004 suddenly started living because we found better treatments for this disease. With these novel therapies used at diagnosis, the sooner we use it, the better the survival. And again, now when I speak to patients, if I tell them that their survival is 7.3 years, that is 2 years. That's data from 2 years ago. Things are happening so rapidly with this disease that I can't even estimate what anyone's survival is because so many transformations have happened in multiple myeloma. And although it is not curable at this time, it is survivable, and people have very good quality of lives with myeloma. However, and the reason that we got to having these great therapies is because of clinical trials. Clinical trials gave us new treatments, and the new treatments have resulted in better survival. But the question is who is receiving both the clinical trials and the better survival? And I can show you that there are some significant disparities in that. With all the new therapies coming out between 2003 and 2007, the survival of Caucasians has, again, significantly improved. However, only smaller improvements have happened with other races, with African Americans not benefiting as much from these new therapies, with Asians having only a 5-month gain in survival, a 6-month gain in survival as compared to 1997, they did not see as much of a benefit from these new therapies. The mortality rate still remains higher for African Americans as compared to other races despite these changes. Here's another slide kind of looking at some different data, kind of the same message, that back in 1998, all the therapies are crummy, and as we went to 2000 to 2009, the therapies got better, and the 5-year survival began to increase. Also during that time, for non-whites, actually with crummy therapies, with just using chemotherapy, non-whites actually, or people of ethnicity, had a superior survival to Caucasians back in 1998 and 2000. But as these new therapies have come out, and as survival has improved, for people of ethnicity, again, we have not seen as much benefit from those new therapies despite the advancements. And so now, what I think is interesting about myeloma is that this is a disease that did not have any survival disparities before. So in 1999 and in the 1980s, everyone did poorly with this disease. But now and this is an emerging disparity, that as we have gone on and improved the therapies, there is an emerging disparity between Caucasians and people of ethnicity regarding this disease. So and I think a very, very interesting study that looked at who is exactly receiving these new therapies. And it's amazing that between 1999 and 2007, that chemotherapy has almost dropped off the map. That back in 1999, about 32% of patients would receive melphalan, which is a standard induction medication for myeloma. Now it's 4%. And for all the other chemotherapies, it's less than 1% of people are receiving chemotherapy for multiple myeloma. And the percentage of patients receiving any novel agents has risen from 4% to 75% in 2007. However, with people of ethnicity, they have significantly less access, less usage of those novel therapies as compared to Hispanics, compared to non-Hispanic whites, independent of insurance status. And this study shows how, despite private insurance, Medicare and Medicaid only, the number of people of other races receiving novel therapies is only 36% of any Medicaid patients are receiving novel therapies which are related directly to survival. And I cannot understand why 47% of people with private insurance, as compared to non-Hispanic whites, why isn't everybody receiving novel therapies for this disease? Because it's, again, so related to survival. And if you look at and part of the reason and part of the problem is that in clinical trials, that we have not pressed the people designing the clinical trials to demand more people of ethnicity in clinical trials. I selected, actually from the NCI, important papers that are on their website related to multiple myeloma therapy. And you look at these treatments that are published in New England Journal of Medicine and in Lancet, that the number of African Americans, despite the disease being twice as prevalent in our population, that again, we are only literally fractions of the people involved in the clinical trials. And the thing is that this isn't chemotherapy anymore, that what we're dealing with are biologic agents that manipulate the bone marrow compartment, the biologic compartment, and we need to have diverse populations in order to understand how these drugs work, if they work, and what specific therapy people should receive for this disease. And there are so many other trials that have been published now. Unfortunately, I was disappointed to see that as I went through some of the modern clinical trials published in the past couple years, there's no race data reported at all for biologic therapy for a disease that's more common in African Americans. So what strategies do we have for screening and prevention of myeloma? We don't have any we have tests to do when we suspect someone to have myeloma. There's no mass screening test for myeloma. There's no prevention therapies that we have for myeloma. So then what are the barriers for timely diagnosis, treatment, and for new therapies for myeloma? And a lot of people have talked today about lack of awareness about research, fear, and distrust, but what I would like to do is to recruit you all to be advocates for this disease, educate people on multiple myeloma awareness. So I am so happy to be able to speak in front of you today because I would like to recruit all of you to be able to go back to your homes, your communities, to your churches, and talk about this disease called multiple myeloma so people can be screened and receive the newest therapy. There was a study that was done in Jacksonville, Florida by Mayo Clinic, where they had partnered with African American churches, going to the community and educating people about this disease. They found out that 88% of people in the churches in Jacksonville had a primary care provider, but 67% had never heard or received any information about multiple myeloma. Again, with this disease being twice as common in their population, they had no idea about the disease. When I did research in multiple myeloma, lab research in myeloma, and my mom she's the smartest person, besides my wife, she's the smartest person in the world. And I went to go I'm getting in my car, I'm backing out of the driveway after I picked up a TV and some money from my mom. And then my mom is waving goodbye, and she says, good luck studying melanoma at Dana-Farber. And I stopped the car, and I was like, Mom, I study myeloma, multiple myeloma. And she says, isn't that melanoma? And I said, melanoma is, Mom, you are 78 more times likely to have multiple myeloma than melanoma. Everybody knows about melanoma. Half in Jacksonville, and when I surveyed people at a cancer conference in Milwaukee, an African American cancer conference in Milwaukee, 88% of the participants were unaware of multiple myeloma. That's why I would like to recruit all of you to teach people about this disease. And I have teamed up with the Jane Creamer Foundation, and we have gone to church events to empower and educate people about multiple myeloma. And the Jane Creamer Foundation pulls church groups together, and they have these multidisciplinary events where they talk about nutrition. They have exercise programs, which I got exhausted at, but they also gave the opportunity to teach about myeloma. And it was an excellent opportunity to talk about myeloma. And one thing that I kept presenting is a simple mnemonic that is think back. To ask yourself, could I have myeloma? Should I ask my doctor to check if I have myeloma? And think back. The B stands for back pain, which is a presenting sign of myeloma. A stands for anemia, a low red blood count. C stands for calcium or confusion because of high calcium levels. And K stands for poor kidney function. And I should mention that there was a study that was done that looked at the common presenting features of myeloma in African Americans, and it was actually high calcium and poor kidney function. So if you have patients or know of patients that have high calcium or poor kidney function, they should be screened for this disease. So one thing to break down the barriers for myeloma disparity is educate the community. Bring the education to the community. To put out a flyer that says multiple myeloma facts. So I did a talk in Milwaukee. I put up a sign that said, Craig Cole's talking about myeloma. 3 people showed up. Why did 3 people show up? Because no one knows what myeloma is. You know, I sort of said quasi-duodenal facts, or megesterol, which is Icelandic for myeloma. No one's going to stop to hear about megesterol, or whatever how you pronounce it, because I'm not Icelandic, but no one's going to stop and do that. So what I changed my talk to is a blood cancer that affects our community. In the next year, I had about 60 people show up when I had 3 people when I put up a sign about myeloma. So don't challenge people's healthcare literacy. Use terms that anyone can understand and stress the importance that what you want to do is you want to educate about this disease, that you don't, it's not medical, it's not scientific, it is educational. And empower your audience that teaching about myeloma is not enough. People, this is a disease of older persons. They need to be empowered. They grew up in a day where you never ask your doctor questions and you never question your doctor. You have to empower patients and empower people to say, I thought back and I think, and I know I have kidney function problems, maybe I should be screened for multiple myeloma. So empower your patients and give them permission to ask their doctor questions and question their doctor. And stress, again, just like what has been mentioned earlier, stress the importance that clinical trials and cancer research is an empowerment tool. It gives you the newest therapy for this disease, and therefore everyone who has myeloma should be involved in a clinical trial because that is where the cure lies. Use resources in the community, overcome healthcare illiteracy, and again, I'm hoping that I have educated all of you about a little bit more about multiple myeloma so you can take that to your communities and then spread the word about this disease. So in conclusion, multiple myeloma is a common hematologic cancer of the plasma cells within the bone marrow compartment. It's twice as common in African Americans compared to all racial groups and ethnic groups. The best method of detection is knowledge. Again, there is no general screening test for it. There is knowledge, and we have to impart that to our patients along with empowerment. And with advances in science and clinical trials, patients with myeloma, and hopefully everyone with this disease, will have longer and better lives. The way that you can learn more about it, the Leukemia and Lymphoma Society, the MMRF, the IMF, and of course the National Cancer Institute, all has information about this disease. And feel free to give me a call or send me an email, because I would be also happy to help. Thank you.
Okay, we have, is this on yet? Okay, we have failed miserably at our commitment around time. We hope that we have balanced that with the amount of information that you have received. If you have a question, I am now committing my 3 speakers to be in the hallway 45 seconds from now. Now, if you're not happy about it, talk to the announcer. You saw that beautiful young lady who came up and whispered in my ear. Now you know what you whispered. No, we can't. But I actually want to talk to you anyway because I got stuff I want to talk to you about. So we're going to end the session.
Come on now.
It's
Talk to the people who told you to stop. These people have done too much to deny them at least a question. That brother just put on one of the best presentations I've heard in years. And he just slowed down because he didn't have no time. I got to honor him. And sickle cell is one of the only diseases that directly affects us, and we're going to push it to the side in the hallway.
I might not be here next year, but we're taking one question from the floor.
Thank you very much. All right.
Bring it on.
See, that's what I'm talking about, advocacy.
No, bring it quick. Bring it quick, though, brother. Bring it quick.
Look. You have presented, and I really want to compliment all the information that you and the captain gave, because in fact, in a different time, in a different setting, we would have been able to get a lot more. But I got a brother and a sister who died of sickle cell. I got a daughter who is, how old is she? Who? Boy, you know I'm a father. I don't even know how old my children are. She's 32 years old, so that idea of knowing that she might not live to be 40, it is painful to sit here and hear the disease that you're talking about. I almost get sick and depressed listening to you. But that's also what happens to the patients and the people who have it. We must get together and try to respond to what you're saying. You're talking about newborn testing for sickle cell. You got the National Healthy Start Association. You ought to hook up with them and make that a part of an effort. Whether we get authorization now or not, we're still going to have to keep on pushing to keep it, because you got to get authorization every year until they give us some money, and then you got to watch that once you get it. So we want to educate, build capacity, and I want to challenge the forum, Minority Quality Forum. We got to take this thing on the road. We got to go from national to regional to local and build that base up so we got some advocacy, some people that action who can move on the things. And the brother, again, I'm going to tell you, man, if you was doing this at 8 o'clock in the morning, I'd have been taking all kind of notes. But I hope you make your stuff available on the web, because I want to read more about it, because it sounds like everything you said I got. Okay?
All right. Thank you very much for your time and attention. It's been an entertaining session. Y'all got to go out in the hallway. There's people that want to talk to you. Get out. Here we go.
You're not taking my question?
No, we can't, because I'm all, yeah, no, but in the hallway, we're going to take all the questions.
No, because mine is so much to give some information.
But I can't, though, because I'm already in trouble. I would like to, and put on your comment cards 2 things. Next year, longer sessions, and that we moderate the number of slides per session, because